The next area we're going to discuss is substance abuse. And I thought as we start talking about substance abuse, we'll start with a question. In the past year, a man has been arrested twice for driving while intoxicated. He is able to perform his activities of daily living without the use of alcohol and restricts his drinking to weekends. The client meets the criteria for which of the following: alcohol withdrawal syndrome, bad judgment syndrome, substance abuse, or substance dependence. Now, if we take a look at those answers, note that he has been arrested, but he's also able to function without alcohol and restricts his drinking to weekends. So that means that it is number 3, substance abuse. Substance abuse can be defined as substance use that leads to legal, social, or medical problems. Now, in order for addiction to be present or dependence to be present, we have dependence upon the substance with compulsive use. So this means that if you're dependent, you don't just restrict your drinking to weekends. If you're dependent, you'll be drinking on a daily basis. And usually tolerance develops. Tolerance means that you need more of the same substance in order to get the desired effect. So for instance, if a group of people were out talking and saying, somebody said I had a substance abuse problem. I don't think so. My buddies and I, we go out drinking, and they're all drunk, and I am still sober, and I match them drink for drink. I don't see how I could be an alcoholic. Well, what that person has just described is dependence, is tolerance. And it takes more alcohol to get him drunk than it does the other people. So what he's described is tolerance, which is a classic feature of substance abuse. Another feature of substance abuse is physical dependence, which means that the patient gets physical symptoms when the substance is withdrawn. And this would be the case in an alcoholic. When the substance is withdrawn, they go through withdrawal symptoms. You can also have physical dependence on drugs like caffeine. And if you don't get your caffeine, you get irritable and headaches. This is a physical dependence. Psychological dependence means you have an intense craving for the substance. So you want the alcohol, you want the caffeine, you want the heroin, you want the cocaine in a serious way. So addiction usually has the compulsive use, tolerance, physical, and psychological dependence. Some of the defense mechanisms that are used in substance abuse, probably the biggest one is denial. I don't have a problem with alcohol, is what the patient will tell you. I could stop anytime I want. Now, I don't want, but I could stop. Projection, so that they project those feelings onto others. I saw a cartoon once that said, if you were married to you, you'd be an alcoholic too. That type of thinking. And rationalization. Well, no, I really don't need alcohol. The reason I go to the bar every night is for socialization. Or once this project is over at work, I won't drink anymore. So there's always a rationalization. I'm not drinking because I need the alcohol. I'm drinking because my boss drinks and I need to keep him company. Otherwise, I might lose my job. So there's always a bit of rationalization in there. Let's look at another question. Following withdrawal from alcohol, a client is to receive disulfiram antabuse. The medication is prescribed for which of these purposes? To minimize the effects of alcohol, to improve detoxification by the liver, to increase her utilization of vitamins, or to help her refrain from drinking alcohol. And the correct answer is number 4, antabuse. Disulfiram is used to help people refrain from drinking alcohol. It gives them what I call won't power. They won't drink. Now, if patients take antabuse, we know that antabuse interferes with the breakdown of alcohol. So when they take antabuse and they drink alcohol, they'll get very sick. They'll have severe nausea and vomiting and flushing and confusion. So that what we do is we give them the medication, let them know how sick they'll get if they drink. And so this is a very strong incentive not to drink alcohol. There are some teachings that you must do for any patient taking antabuse. And the first and most important is no alcohol in any form. This means no aftershave lotion that contains alcohol, no mouthwashes that contain alcohol. We don't want to wipe down their skin or cleanse their skin with alcohol wipes, because even the absorption of alcohol through the skin can cause the antabuse-like reaction. So they should not take cough syrups that contain alcohol. They should not take anything that is an elixir, because that contains alcohol. Now note that you should have no alcohol for 2 weeks after the last dose of antabuse. I think you might find questions on the exam that ask how long the patient needs to abstain from alcohol after taking antabuse. And the answer is 2 weeks. Now this means that they can't say, well, today is Friday, I want to go out with the guys, I think I'll skip my antabuse, because he's still got antabuse for the last 2 weeks in his system and he still would get sick. It's also important that people taking antabuse carry ID about antabuse. For the very reason, if they were in an accident and brought into the emergency room and had lacerations, the first thing we tend to do is prep the skin with alcohol, and this could induce an antabuse reaction. So it's really important that they have ID that they're taking antabuse. Another question for us. A client asked the nurse about participation in Alcoholics Anonymous. In addition to arranging for a visit by someone from Alcoholics Anonymous, the nurse should explain that the primary purpose of the organization is to 1. Explore the individual member's need for dependence on alcohol. 2. Help members abstain from alcohol. 3. Teach members how to manage social situations without the need for alcohol. And 4. Increase the public awareness of the results of alcoholism. And the correct answer is number 2. The primary purpose is to help members abstain from alcohol. The other answers are lesser purposes, and they may be accomplished by AA, but the primary purpose is to help members abstain from alcohol. Alcoholics Anonymous is one of the 12-step programs. In fact, it was the first of the 12-step programs. Alcoholics Anonymous is sometimes referred to simply as AA, and it is by far the most effective means of dealing with alcoholics. It's much more effective than all the psychiatrists and social workers and nurses put together. The principle with Alcoholics Anonymous is that this is a group of alcoholics. Everyone who belongs to AA is an alcoholic, and they support each other. Now, there are a number of sister organizations, if you will, that use the same 12-step program. Al-Anon is for the significant others, the spouses or the people that are living with alcoholics. Al-Ateen is for the children of alcoholics, recognizing that these people have a lot of difficulty in living with an alcoholic. Now, there are other groups that are based on the same 12-step program, Narcotics Anonymous, NA. There is Sexaholics Anonymous, Overeaters Anonymous, and they all use the same 12-step program. Now, in the 12-step programs, the first thing that the person has to do is admit that they have the problem. I am an alcoholic. I am an addict. And the second thing they have to do is admit that they are powerless over the substance, and they need help from outside of themselves. So they need help from, the term that's used in AA is the term higher power. Now, AA is not a religion, so they don't care how you define the higher power, but recognizing that you need to get outside of yourself to get assistance in dealing with your substance addiction. AA requires people to admit they have a problem, and this is often one of the hardest things to do. When people introduce themselves in an AA meeting, they'll say, I'm so-and-so and I'm an alcoholic. And this is one of the things they need to do to admit that they have the problem. As the steps go on, they recognize that they not only have the problem, they are powerless over the substance, they need help from outside themselves, from the higher power. They go on then to recognize that they may have harmed people, they try to make some restitution. There are a number of steps. You don't need to recognize them all. Finally, the people who go through the entire program may end up being sponsors for others who are starting the program. So each person that comes into AA usually selects a sponsor, and the sponsor is someone whom they can call upon. So if at 3 o'clock in the morning they feel they absolutely have to have a drink, they call their sponsor, who will either talk to them on the phone or come to them and help them through that crisis. This, as I said, is by far the most effective means of keeping people sober and away from the substance, much more effective than other types of therapies. What we frequently do is help the people go through withdrawal and then refer them into 12-step programs. When patients are discharged, they are frequently going into a 90-90 program, which means 90 meetings in 90 days, so that every single day they are required to go to a 12-step or an AA type meeting. It's extremely effective. Let's take a look at a question. An adult woman is admitted to the detox unit for alcohol withdrawal. Her husband tells the nurse that he is fed up. Either she gets treatment or he is leaving her. 2 days later, the woman develops delirium tremens. At this time, which of these nursing diagnoses should be given priority in caring for this client? Number 1, potential for physical injury related to impulsiveness. Number 2, noncompliance with medical regimen related to denial of illness. Number 3, anticipatory grieving related to her husband's threat of abandoning her. And number 4, translocation syndrome related to transfer to a strange environment. Now we're asked to take which of these is priority. Now all of these diagnoses are official diagnoses and could be related to this patient's case at some point. But when it says at this time, you look back at the question and say, what is going on right now? This patient is in delirium tremens. So the correct answer is number 1, it's safety, potential for physical injury related to impulsiveness. And patients who are in DTs often are quite impulsive. They may do very irrational things. They may injure themselves or others. So safety is a very serious concern for patients who are undergoing withdrawal symptoms. Now I want us to think about the management of patients who are undergoing withdrawal from various substances. If we take a look at the picture, when patients are abusing central nervous system depressants, these might be drugs like sedatives, hypnotics, opiates, even alcohol fits into this category. If you can just imagine that all the neurons in the brain are covered with depressant. So all these neurons have been depressed. If you suddenly withdrew that, it's almost as though they overfire. And these patients are at high risk then for seizures. So when patients have been abusing central nervous system depressants, we usually give them the same or a similar drug and gradually with decreasing amounts to prevent seizure activity. So if a patient was a Valium addict, we give them gradually smaller amounts of Valium. If they were a heroin addict, they're going to be getting methadone because heroin is an illegal substance. If they were an alcohol addict, we might give them Valium, Librium, Ativan to help them go through that withdrawal process so they're less likely to develop seizures. Now you might wonder what those two little eyes there with the little tiny dots in them are on the picture. This is to remind us that people that are abusing opiates tend to have constricted pupils when they are using the substance. Now, of course, as they go through withdrawal, the pupils will tend to dilate a bit more. Now, we also want to talk a little bit about withdrawing from central nervous system stimulants. Drugs like cocaine, amphetamines, hallucinogens, the LSD, the PCP type drugs. Now, those pupils there are big and dilated because people that are abusing your amphetamines, for instance, and hallucinogens will often have dilated pupils. So it's a warning sign when somebody wears sunglasses inside and out. If they're wearing them indoors and the light is not too bright, you worry a little bit. Are they abusing a substance that causes their pupils to be dilated? Now, if you're abusing a stimulant and you withdraw the stimulant, you're just going to get exceedingly depressed, but you're not likely to develop seizures. So we can abruptly withdraw stimulants and hallucinogens from the patient. They may get profoundly depressed, but they aren't going to go into seizure activity. So we don't have to do a gradual withdrawal for these types of drugs. Let's take a look at a question. A 25-year-old woman has admitted herself to the psychiatric unit for treatment of Valium addiction. She is currently taking 150 milligrams PO of Valium per day, which she gets from various doctors or buys off the streets. The first night she is on the unit, she dresses in a short, see-through nightgown and approaches the male nurse. She states she is, quote, coming down, end quote, and just needs a little comforting and conversation. What is the best initial response by the nurse? Number 1, please put on your bathrobe and then we can talk. Number 2, I'm very busy now. Maybe one of the other nurses can help you. Number 3, what seems to be the problem? And number 4, what you are experiencing is very common. It should get better soon. Now, if you look at the behavior described in the question, what is this young lady trying to do? It looks to me like she may be trying to seduce the male nurse because she's wearing a see-through nightgown. So this is manipulative type of behavior. Whenever you see manipulative behavior, the nursing response is to set limits. So if we look back at the answers, answer number 1 says, please put on your bathrobe and then we can talk. So it says you're not going to seduce me. Put on your bathrobe, behave appropriately, then we'll talk. So he doesn't put her aside and say we can't talk, but he says you must behave appropriately. The other answer is the one that says I'm very busy now, ignores the behavior. It's almost as if he's frightened of her and says, go talk to somebody else, don't bother me. The answer that said what seems to be the problem, again, ignores this manipulative type of behavior. As a nurse, we're going to confront the manipulative behavior. And number 4, again, what you're experiencing is very common. That, again, ignores the manipulative behavior. So whenever you see in a question manipulative behavior, your nursing response is going to be to set limits. Another question for us. 3 days after admission for treatment of Valium addiction, the client is seen in the parking lot talking to a male visitor. When approached by the nurse about leaving the unit without permission, she laughs and says, "Ha ha, I just needed to see my old man. He doesn't like hospitals. 10 minutes is no big deal," end quote. What is the best initial nursing intervention? 1, next time ask a staff member to go with you. 2, you do not have past privileges and your willingness to follow the rules is important to your treatment program. 3, I'm going to have to report your activities to the doctor. Or 4, I can understand needing to see your friend, but next time, invite him to the unit. And the correct answer is number 2, setting limits. Now, I don't know what this young woman is doing in the parking lot talking to her, quote, old man. Don't know if you're suspicious of what she is up to. I'm a little bit suspicious. I think she might be trying to get drugs. But in any event, the behavior is not acceptable behavior, not obeying the rules, and you will confront that behavior. There are 2 answers in the question that you know automatically are not correct. If you look at the question, choice 1, next time. Choice 4, next time. Next time is not therapeutic. On nursing tests, on a psychiatric issue, you're going to take your action now. You're not going to say next time. You're going to set limits now. And it's much better to confront the patient than it is to talk to the doctor about it. You will talk to the doctor, but initially you're going to confront the patient about their behavior and set the limits. Another question for us. A client admitted for Valium withdrawal left the unit without permission. That evening, she appears calm, happy, and more social than before. You suspect she has taken some illegal drugs. What should you do first in handling this situation? Number 1, talk to her about your observations. Number 2, chart your observations. Number 3, search her room without her knowledge. Or number 4, immediately call her psychiatrist. Now the question says, what should you do first? And if you look at the data, you think she's taken some illegal drugs. So you, number 1, talk to her about your observations. I notice that you are more calm, happy, and social than before. I wonder if you have taken some illegal drugs. She may or may not admit it, but at least now she knows you know. So you would confront her with her behavior. Let's look at another question. A young woman is being treated for Valium withdrawal. Which behavior indicates she is ready for discharge? 1, she has made a plan to return home and continue therapy. 2, she has talked to her boss about returning to work. 3, she has identified her weak areas and is working on them. 4, she is now asking the staff for advice about her future. So indicate she is ready for discharge. The answer is number 1. This would be the most complete answer. She's made a plan to return home and continue therapy. She will need continued therapy, either the psychiatric consultation and continued work with a psychiatrist or a social worker or a therapist. She also will probably be referred to a 12-step program such as Narcotics Anonymous, but she will need continued therapy. The other answers are all steps along the way, but choice number 1 is the most complete answer. Now, I want us to take a moment and talk about substance abuse, particularly as it relates to nurses. Sometimes they put questions on NCLEX about nurses who may be alcoholics or abusing substances. Some of the things that might give you warning signs that a nurse was abusing a substance: excessive absenteeism, or the opposite, overworking. If the source of drugs was the hospital, then this nurse is likely to want to be working at every opportunity and will take the opportunity to do extra shifts. Now, I must make a little aside here. Just because you work hard doesn't mean everybody's going to suspect you of being a substance abuser. But those characteristics combined with others might begin to make a picture of substance abuse. Mood changes and inappropriate affect go along with substance abuse. Oftentimes people with that are abusing substances are apt to be quite irritable. Then they may be suddenly much more cheery after they've taken their substance. They may have poor judgments. There may be changes in nursing care. So we may note that their nursing care quality has decreased. If there are drugs that are missing when they are on duty, maybe they smell like they have alcohol on the breath. Frequent trips to the restroom and then changes in behavior immediately after the restroom trips. Frequently asking for night shifts because there's less supervision at night. It would be easier to divert substances during the night shift. If patients complain of poor pain relief when one particular nurse is on duty, but whenever they get their pain medicine, when other nurses are on duty, they get the pain relief. This would be something that would be a cause for concern. Now, what should we do if we suspect that a nurse that we may be working with may have a substance issue? Your first and foremost obligation is to the safety of the patient. So you need to assure patient safety, which means you're not going to let someone who comes to work obviously drunk take care of patients that night. You're going to have to notify the supervisor and let them know that this nurse is not in any condition to take care of patients. You need to verify if there are other people that have witnessed the behavior, that have smelled the breath. Then keep your own little record of what's going on so that it's not just I said, he said type of thing, so that you have collaboration of your, or corroboration of your observations. Usually the employer will do some type of confrontation with the employee, and most of the time our goal is to rehabilitate people rather than punish. So usually they'll offer some type of treatment option. If the nurse would refuse that, then they may well be reported to the Board of Nursing and have their license removed. Frequently, we like to get them into treatment programs. Most states have treatment programs for nurses with substance abuse issues. And usually what happens is the nurse will either have their license temporarily suspended or be in the treatment program and be temporarily not employed. Once they complete the program, then they may be coming back to employment as a nurse. If they refuse treatment, the Board of Nursing is likely to revoke their nursing license. But that's a process that has to go through. It can't happen just overnight. If drugs were being stolen from the hospital, then law enforcement must be involved because this is a crime. And it's a federal crime to use, to divert controlled substances. This completes the section on substance abuse.